Hello, everybody. My name is Professor Zachary Munn, and it is my privilege to talk to you all today about grade and why we use grade to move from the evidence to making trustworthy recommendations in guidelines. Thank you for the invitation from my dear colleague, Professor Fudan, to speak to you all today. Firstly, just some of my disclosures. So I am the Director of Health Evidence Synthesis, Recommendations and Impact at the School of Public Health at the University of Adelaide. I'm also the Centre Director of the JBI Adelaide Grade Centre, and I am the past chair of the Guidelines International Network and a current board trustee. I receive funding for systematic reviews and guidelines in the work that I do, but this funding comes from charities or governments or non-governmental organisations which are not for profit. I do not receive funding from pharmaceutical or medical device groups. So today I'm going to talk about why we should use grade, what is a grade approach, and how we can form trustworthy recommendations with grade. So let's start off with why grade. And perhaps it's useful to talk about the original approaches to developing recommendations in guidelines. So if we look back in time, historically, the most common approach to developing recommendations in guidelines was using the GOBSAT method. This stands for Good Old Boys Sat Around the Table, and it really was the early approach to developing recommendations based on the powerful people within a field who would often make recommendations which would protect their vested interests or their status quo or their positions of privilege or power. So somewhat conflicted recommendations. And as opposed to evidence-based medicine, we could consider this eminence-based medicine. Now, this was the original approach, and many groups around the world realized we should not be using an approach like this. And of course, Professor Gordon Guyatt talked about the need to move to evidence-based medicine. So many guideline groups around the world started to come up with their own systems for developing recommendations, which privileged research evidence over expertise in the construction of recommendations in guidelines. But what we can see is that lots of different groups created lots of different systems. And it seemed like every single group around the globe started to come up with their own evidence classification system and evidence assessment framework for making recommendations. So very soon, almost every single professional society, every government had their own levels of evidence or hierarchies of evidence and recommendation construction systems. And it became incredibly confusing for everybody. So the grade working group was established to develop a unifying, transparent, and sensible system for grading the certainty of evidence and making recommendations. And after 20 years of much confusion, I am now glad to say that grade really is the gold standard for establishing certainty in the evidence and making recommendations. And we can see that there are now many groups and professional societies around the globe who actually do use grade. Grade approaches can be applied in systematic reviews, health technology assessment, and particularly in guideline development. And there are many people who are contributing to grade. There's over 600 people now a part of the grade working group, and we run regular workshops at GIN, Cochrane, WHO, and JBI events. In terms of guidance for grade, if you're interested, there is a series in the British Medical Journal which outlines the basics of grade, but for ongoing updates to grade, these are normally published in the Journal of Clinical Epidemiology, and please do check out these papers. There is also a handbook for grade, which is currently being updated, and there is software for using grade as well. So that is who grade are. Now let me introduce you to the grade approach. So when we form recommendations in guidelines using the grade approach, we need to consider the balance between benefits, harms, and burdens of any treatment strategy or any recommendation. This is really important because historically, sometimes people focus only on the benefits and not enough on the harms and burdens of a treatment strategy. We also need to consider patients' values and preferences, and particularly when we're making recommendations from a population perspective, whether or not our recommendations are going to reduce or increase health disparities and inequities. Of course, we need to consider resource use as well and how much the intervention will cost to a health system. And along with feasibility, if it's actually going to be feasible to do and acceptable to all key stakeholders. And all of this is balanced by our certainty of the evidence. But the question is, how do we determine our certainty of the evidence? Well, before we discuss that, let's just discuss, well, what actually is the evidence? What do we mean by the evidence when we're talking about certainty in the evidence? Well, firstly, when we talk about evidence-based guidelines, evidence-based medicine or evidence-based nursing, when we talk about the evidence should be a systematic review. Evidence syntheses and systematic reviews are the basic unit or core unit or the foundational cornerstone of evidence-based healthcare and evidence-based guidelines. So when we talk about what is the evidence, we're not talking about individual single studies, we're talking about the systematic review. So here's an example systematic review, which I led some years ago, which looked at rinse-free hand wash for reducing absenteeism among preschool and school children. So hand sanitizer, perhaps alcohol hand gel, for reducing sickness among school children. Here is an example of one of our meta-analyses, which looked at absenteeism due to any illness in the hand sanitizer group versus a control group. And what this found was an incident rate ratio of 0.82, supporting rinse-free hand wash or hand sanitizer in terms of having less days sick off school. And this is an illustration or another way to demonstrate that information in a way which is actually understandable. So here we have our incident rate ratio of 0.82, but this is sometimes difficult for people to actually understand or conceptualize. So whenever we create a grade summary of findings table, we always present an indicator of the baseline risk and the comparative risk, or what we call this data in natural frequencies. So without rinse-free hand wash, there were 16 days absent per 1,000 school days, but with rinse-free hand wash, there were 13 days absent per 1,000 school days. But the question is, can we actually trust this result? How certain are we that this result is true? Should we use this result to underpin recommendations and guidelines? That is a big question. So we need to establish our certainty in this result, and we can do this using grade. So when we use grade, we have our systematic reviews, and if we have, we may do a systematic review of randomized studies, or we may do a systematic review of non-randomized studies. So a body of evidence or results from randomized studies will start off as high because they obviously have randomization embedded within them, and we know randomized controlled trials are the gold standard for research when assessing the effectiveness of an intervention. Non-randomized studies will start off as low, and that's our initial certainty of evidence. So grade have 4 levels for certainty of evidence: high, moderate, low, and very low. And randomized start off as high, non-randomized start off as low. Then we need to consider what we call the 5 domains or factors that can downgrade the certainty of evidence in a particular result. The first is risk of bias or methodological limitations. So if there are serious flaws in the way that the studies have been conducted or interpreted, or there are issues with the risk of bias, then we may actually downgrade our certainty of evidence from high, perhaps to moderate or even low. Another thing we consider is inconsistency. So if the results of the studies included in our meta-analysis or our synthesis are very different from one another and telling different stories, and there is no good explanation for this inconsistency, then this is another reason why we would downgrade. We also need to consider directness and whether or not the results from these studies are actually applicable or provide direct evidence for our context and our jurisdiction that we're interested in. So we also need to consider how relevant or transferable or applicable these results are. We also need to consider imprecision, and particularly the width of a synthesized, the confidence intervals around the synthesized point estimate, and whether or not they cross important decision-making thresholds in regards to treatment and, let's say, minimally important differences. And we also need to consider publication bias and whether or not we suspect that publication bias may be present. And that would also, if we did suspect it, we would also downgrade the certainty of the evidence. Now, there are also 3 domains which can upgrade the certainty of evidence, and these are applicable to non-randomized studies. So if there is a clear dose-response relationship between the exposure of the intervention and the outcome, this can increase our certainty. So every time we see a bit more of the intervention or a bit more of the exposure, and we see a corresponding increase in the outcome, this is example of a dose-response relationship. And you may recall that this is one of the Bradford Hill viewpoints on causal relationships. If we are considering a consistent and precise large effect from all studies, then this can also increase our confidence. And finally, if we are seeing if we suspect that there is likely residual confounding which hasn't been adjusted in the analyses, but despite this residual confounding, we're still seeing a result, or we suspect that the result may be even larger, if this confounding had been adjusted for, this can also increase our certainty. And then after we've considered all of these domains, we end up with our high, moderate, low, or very low certainty in the evidence. Now, let's go back to my example systematic review now. So we have this incident rate ratio of 0.82, and at the end of the day, we actually had very low certainty in this. The reason for this is that there was a very high risk of bias across the studies. There was also some statistical heterogeneity, and some issues with imprecision as well. So unfortunately, although we did this systematic review and we found this result, we actually had very low certainty in it at the end of the day. Okay, just one caveat to what I've mentioned. If we are using a risk of bias assessment tool called Robbins I, the risk of bias in non-randomized studies of interventions, we can also start off as high for non-randomized studies. But regardless of whether we use Robbins I or the Newcastle Ottawa scale or the JBI tools, we should normally end up in the same place, regardless of the tool that we use. Okay, so that's how we use grade to establish the certainty in the evidence. Now what I want to do is discuss how we can make trustworthy recommendations with grade. So as I mentioned, when we make recommendations, we need to consider all of these different aspects. But this is a lot for a guideline panel to actually consider and then balance in their minds as they make a recommendation. And for many of you who have been in guideline panels, you may have had this experience where there can be some disagreement. And this is because when we work with guideline panels, we are working with people who are incredibly passionate, incredibly knowledgeable in that field. Sometimes we're discussing recommendations in what is really their life's work. So of course when we have such motivated, passionate and experienced people all sitting together to discuss something they are very interested in, there can be sometimes issues with disagreement and these kind of things. Sometimes people want to just keep things how it has always been as well. Just keep things going how it's always been and not change things as well. Sometimes people get fixated on perhaps one new study rather than all of the evidence that exists. And the problem that you can sometimes fall into with guideline panels is that you go around in circles, you're discussing lots of different things, you come up with old arguments that have already been discussed, and it can be very tricky. It's a little bit like herding cats. And this is why the grade group advocate for the evidence to decision framework approach to developing recommendations in guidelines and with guideline panels. And this is what the whole process, basically, once we've identified our problem with all of the key end users, we've come up with our questions and we've done our systematic review, we then go through all of these evidence to decision criteria, and we consider, the panel one by one needs to consider the research evidence for each of these criteria and any relevant additional considerations for each of these criteria. And the panel then need to make judgments for each of these criteria, explicit judgments about each of these. And then once they've done that, then all of these considerations lead to making a recommendation. So the evidence to decision framework is incredibly useful to provide a structured approach, making sure that everyone considers the research evidence and additional considerations for each of these criteria. And then the panel does make this judgment on each one of these before going to a recommendation, which then, of course, is hopefully implemented and improves outcomes. So what I want to do now is run through an example quite quickly on this whole process for one PICO that we did in a guideline for the Royal Australian College of General Practitioners here in Australia. This was looking at smoking cessation and interventions to help with smoking cessation. This is a little bit out of date now, so please don't take the evidence at face value, but I just want to show you the whole process. So these were guidelines for smoking cessation. Here's a copy of the guide or the guideline, and this was supported by summary of findings and systematic review results and the evidence to decision frameworks that we developed as well. Okay, so let's go through one of the PICOs in this question. So for clinical question 2, the question was, is a combination of varenicline and nicotine replacement therapy more effective than varenicline alone? And here is our PICO and study designs for randomized controlled trials. We found 2 studies at that time, which looked at varenicline with nicotine patch and varenicline with a placebo patch. You can see here that people were more likely, there was an odds ratio of 1.62, people were more likely to quit when they had the varenicline plus nicotine patch. So we also looked at smoking dependency, and also, very importantly, we looked at adverse events or harms of this intervention as well. We assessed the risk of bias of the studies, as you can see here, and we generated a grade evidence profile, which found that 96 more people per 1,000 would successfully quit smoking using varenicline and nicotine replacement therapy versus varenicline alone, and we had moderate certainty in this evidence. So that was our grade evidence profile, but then we need to actually take that evidence to the guideline panel and make a recommendation. So first off, we need to decide, well, is this problem a priority? And it is, of course, across the whole world, but also in Australia. There is too many people who smoke, and there are too many, the health impacts of smoking are very large. So it is definitely a problem. In terms of the desirable effects, they were deemed to be moderate. The fact that we actually saw 96 more people quitting smoking, that was deemed as quite moderate, not a large, but definitely more than a small effect. And then in terms of discussing the other outcomes, they were also deemed moderate. In terms of the undesirable effects or the harms, really these were considered trivial. They looked quite small. There didn't seem to be too many differences between the groups. Our certainty of evidence was moderate here. In terms of values, there was really no important uncertainty or variability in how much people actually valued smoking cessation in this case. In terms of a balance of effects, it really did probably favour the intervention. And you can see once again that this is a panel making these judgments and providing additional considerations here as well. In terms of acceptability, when we thought about it from the patient and the clinician perspective, it really was probably quite acceptable, and this is what the panel all agreed to after looking at the research evidence, and also feasible as well. And you can see here all of the research evidence information has been populated. Then when doing a summary of judgments, you can see everything that the panel decided, and this ended up with the guideline panel making a recommendation that for people who are attempting to quit smoking using varenicline, clinicians might recommend the use of varenicline in combination with nicotine replacement therapy compared with varenicline alone. This is how we flow through from our PICO to our grade evidence profiles through the evidence decision frameworks, and then came up with our recommendation. So just quickly summing up the whole process, we have our panel who prioritize questions. They prioritize the evidence syntheses and the outcomes that are going to be looked at. We do our systematic reviews. We create our grade evidence profiles. During that, we rate the certainty of evidence for each outcome, considering the risk of bias, inconsistency, indirectness, imprecision, and publication bias, along with our upgrading factors as well. We grade our overall certainty of the evidence, which then feeds through to the panel and recommendation making process. The panel then consider whether or not to make a recommendation for or against a particular strategy or treatment, and whether that should be a strong or conditional recommendation. They need to do this by balancing all these things: the certainty of evidence, the values and preferences, the balance between the benefits and harms, resource use, equity, feasibility, and acceptability, which is all transparently recorded in this evidence decision framework. And this evidence decision framework helps these structured decisions before the panel finally makes their final recommendations. And that is how we can use grade to move from the evidence to make trustworthy recommendations in guidelines. Thank you for your time today. If you'd like to reach out and contact me, my details are here on the slide. I wish you all a very good and successful conference, and thank you again for the opportunity to speak to you all. Thank you very much.